A very good evening to one and all. On behalf of Classroom Series, I would like to invite all of you for this expert talk on traumatic brain injury. Today, we have with us two speakers. On behalf of Classroom Series and Neurocritical Care Society of India, I would like to thank St. John's Medical College to give their recorded version of the seminar which happened on the occasion of World Head Injury Awareness Day. First, we have with us Dr. Prof. Menon, who would be talking his experience on personalizing precision medicine in the field of traumatic brain injury. This would be followed by a talk by Professor Umamaheswar Rao, who will give his personal experiences of his scope of treating traumatic brain injury over decades of practice. So, without much delay, this is the first talk by Prof. Menon.
Menon made a history by being the inaugural director of critical care. Delay, I would like to introduce our first speaker, Professor David Menon. He's a distinguished teacher in the field of intensive care unit, renowned for his contributions in the neurocritical care. In 1993, Professor Menon made a history by being the inaugural director of critical care unit at Adam Brooks Hospital, Cambridge. He held several positions over the years. He's the director of research, University of Cambridge, honorary consultant neurosciences unit, professional fellow, Queen's College, Cambridge. His research interest has been neurocritical care, secondary brain injury, neuroinflammation, and metabolic imaging in acute brain injury. He has an impressive publication record, including 922 peer-reviewed articles with a H index of 135, average citations about 55,000. His stellar academic career is adorned with several awards: Sir Robert McIntosh Award, Royal College of Anesthetics in the year 1988, honorary membership of Neurocritical Care 2016, and Emeritus Senior Investigator, National Institute for Health Research 2018, and many more to go. He has also been recognized as a visiting professor at renowned institutions like Harvard Medical School, University of Toronto, which shows his global impact. In summary, Professor David Menon epitomizes excellence in neurointensive care. His pioneering research, clinical expertise, and his commitment to global health is truly a transformative legend in this field. We welcome you, Prof. Menon. The stage is yours. Thank you.
So thank you very much, and I'm very grateful to be given the opportunity to talk at this meeting. St. John's Medical College is well known to me. I actually applied to go to medical school there when I was looking for undergraduate medical training, but finally wound up in JIPMA. And I also grew up in Bangalore in the first few years of my life, so it's in some ways a homecoming. So I'll just share screen. So Soumya had asked me to talk about multimodality monitoring and traumatic brain injury, and I understand that this is mainly an intensive care and anesthesiology audience. So I won't talk about the general aspects of TBI management. I'll go straight into the ICU management of patients who come to us. And that has changed over the last few years. In the past, most of our patients, certainly in the West, consisted of patients who had a road traffic accident. They were usually young males with severe TBI. What's changed now is that they're much older. They often come in for reasons of comorbidities or multiple drug therapies, such as anticoagulants, which they had before they had their TBI. And these patients will often come in with multiple trauma because effective trauma care systems scrape patients off the road and get them to survive when in the past they would not have survived. But regardless of the kind of patient who turns up, the current ICU management is based broadly on the Brain Trauma Foundation guidelines, and this is their fourth edition, which says that ICP monitoring is recommended to reduce in hospital and 2-week mortality, CPP monitoring is recommended to decrease 2-week mortality. This is all very evidence-based. There was this version of the Brain Trauma Foundation guidelines really took no account of expert opinion. It was all very heavily evidence-based. And we know that evidence largely is lacking in the management of TBI. The suggestion was to maintain systolic blood pressure at over 100 millimeters of mercury in patients over 50 to 69 years old and over 110 millimeters in younger patients or older patients. A threshold ICP of 22 millimeters of mercury was suggested for treatment as higher values were associated with increased mortality. A target CPP for survival or favorable outcome was above 60 or above 70, and which one of these you chose depended on the autoregulatory status. If the cerebral circulation was autoregulating, then the higher CPP was recommended. If they were not autoregulating, the lower CPP target was recommended. Now, there are several points to make about this. The most important point is that all of these targets are derived from associations between outcome and these physiological endpoints. None of those have been addressed by true randomized controlled trials, and perhaps they are very difficult to do so. But the second thing is, while it provided physiological targets, it provided absolutely no information on how to get there. There were specific aspects of treatment, such as osmotic agents and so on, that were addressed separately. But in achieving these targets, there was very little information that would guide clinicians. But intensive care doctors are really quite innovative and inventive. And as a consequence, every intensive care unit has its own chart where it has a range of interventions to control ICP and optimize CPP. This is the one at Cambridge. It consists of a basic level of monitoring that's initiated, consisting of invasive arterial monitoring, ICP monitoring, a central venous pressure catheter, a cerebral microdialysis catheter, and brain tissue PO2 probe, an attachment to a computer system so that we can address autoregulatory status. With this in place, we proceed to stage one um, management of ICP, and this is probably best referred to as stage zero because here it's really general intensive care management, some sedation, trying to target these endpoints, and then await what happens to the ICP. When ICP and CPP are suboptimal below those thresholds, we have the option of putting in a CSF drain using hypertonic solutions. We tend to use sodium chloride 5% rather than mannitol. And we will drop the temperature to around 35 to 36 degrees centigrade, but certainly aim for normothermia. If that doesn't work, stage three is to increase blood pressure to see whether we can reduce ICP through autoregulation and hyperventilate patients down to CO2 of up to 4. Now, in many cases outside Cambridge, stage 2 and 3 are combined, and it's perfectly reasonable to do so. But then you have stage 4 and 5, which are usually combined as second or third tier therapies, this being first tier, this second tier, and this third tier, consisting of extreme interventions such as hypothermia below 35 degrees centigrade, decompressive craniectomy, and metabolic suppression with anesthetic agents. So you have that in this pictorial depiction here: basic intensive care, blood pressure elevation, optimize oxygenation, reduce carbon dioxide, and we'll talk about CO2 control as an exemplar later. And if that doesn't work, then we use hypertonic saline. You have a salt shaker here. We can use varying degrees of hypothermia. And when this becomes below 35, it's a tier 3 therapy. We can have deep sedation to metabolic suppression and an isoelectric or near isoelectric EEG or a decompressive craniectomy. And as we have, very similarly, other units have similar protocols, and all of us came together in the aftermath of the BEST TRIP trial to develop a management algorithm for patients with intracranial pressure monitoring, the Seattle International Severe Traumatic Brain Injury Consensus Conference, CBIC. And just as I said, you have tier 1, which is basic intensive care, tier 2, mild hypocapnia, neuromuscular blockade, MAP elevation, and the use of vasopressors. If this didn't work, then you had the options of hypothermia, barbiturate or coma, or decompressive craniectomy. And at each of these stages, before we escalate therapy, we need to re-examine the patient and consider whether they need a repeat CT to re-evaluate intracranial pathology and consider surgical options. It's also important to consider extracranial causes for ICP elevation, such as fever or shivering, which can be dealt with without actually ICP-directed therapy. So this is fine, but the problem comes when you look at these stage 3 therapies, these more extreme therapies, where you have the use of ICP monitoring itself, decompressive craniectomy, hypothermia in these two trials. And when you look at evidence-based medicine, the best strip trial suggested that ICP-guided therapy was no better than clinical examination and the use of recurrent imaging. DECRA, the decompressive craniectomy trial from Australia, suggested there was harm from decompressive craniectomy, and Eurotherm and Polar both suggested there was either no benefit or harm from hypothermia. So the problem with these bits of evidence is that they were not really looking at the most severe disease. All of the patients who came to the units were eligible for these interventions. And the ICP thresholds here were 20 millimeters of mercury. This was used as an early intervention. If you had 15 minutes of ICP elevation without any other intervention being tried, and Eurotherm and Polar use this as early hypothermia universally. And the problem with this, to quote Shakespeare, is that diseases desperate grown by desperate appliance are relieved or not at all. These are all hazardous therapies. And if you want to use these therapies, the hazards have to be outweighed by the benefits, and those benefits are only seen in the patients with extreme intracranial hypertension. And these trials really did not choose patients with extreme intracranial hypertension. So let me explain that a bit further. So here we have a patient who actually has an extradural hematoma, an eminently treatable condition, but he had collapsed outside a pub in England and was found only the next morning. He came to us very late, and as a consequence of that, even though the extradural hematoma was evacuated, he eventually died. And at postmortem, you can see the undersurface of his brain. This is a slice through the bottom of his brain, and you can see the uncus of the temporal lobe from that side pressing down on the brainstem and causing a diurete hemorrhage. This doesn't happen at an ICP threshold of 20. We don't know what threshold it happens at, but it's certainly above 30 millimeters of mercury. On the other hand, if you take this patient who's a heavy drinker, she fell down the stairs, had a subdural hematoma, came to us quite promptly, had the subdural hematoma evacuated, but because of persistent oozing due to her coagulopathy, she was left with the bone flap removed, and you can see there's some residual blood and some underlying contusions, but still there's no midline shift, and as it turned out, very little midline shift. Her cisterns were not effaced, and as it turned out, her ICP at this stage was only 18 millimeters of mercury. This is a positron emission tomography cerebral blood flow scan. She was part of a research study. And you can see that despite the low ICP and well-maintained CPP, you've got an area of hypoperfusion on that side. And we don't know why this happens, but it's not because of the ICP. It depends on the CPP, but we don't know what threshold it is. But this patient is not going to die imminently from this, unlike this one where there's imminent herniation. And these have very different risks, thresholds, and urgency for treatment, and therefore different acceptance of iatrogenic risk. And when we talk about those extreme therapies, we should calibrate them to the benefit and the risks associated with both the intervention and the patient. So for one of these therapies, let me give you an example. This is the ANZIX Polar study, and it was a very simple question. Does early prophylactic hypothermia improve long-term neurological outcome in patients with severe traumatic brain injury? What they had was when the ICP was elevated, very early, within the first 72 hours, you had patients who were randomized to either prophylactic hypothermia, 33 to 35 degrees centigrade, or controlled normothermia. And they found absolutely no difference. But these were not sick patients. These are not patients where we would struggle to control intracranial pressure. And what they found was even in the control population where they used normothermia, the intracranial pressure was over 20 millimeters of mercury only for 4% of the monitored time, and the decompressive craniectomy rate was only 3% in both groups. These are not patients sick enough for us to use hypothermia in our hands. So we continue to use hypothermia for ICP control in extreme situations because the risk-benefit ratio is favorable. For a general intensive care audience, I often draw this lesson. This is a completely different disease, a different intervention on which we published in JAMA some time ago. So this is looking at ECMO in patients who had swine flu. Now, one pandemic before the last. And what we demonstrated was that ECMO in patients who had refractory hypoxemia improved outcomes through appropriate control matching and risk adjustment. And that's accepted, that ECMO is an accepted treatment option in severe respiratory failure from a variety of causes, really. It treats extreme physiology, not the primary diagnosis. We recognize that it has substantial risks, much more than conventional therapy of putting a tube down someone's trachea and ventilating them, even with advanced ventilatory methods. However, when these more conventional therapies have failed, outcome is likely to be inherently worse. And in these extreme situations, the benefits of hypothermia are more than the risks of hypothermia. And so we use it. But it is unlikely to show favorable risk-benefit ratio if it is used as a treatment for a specific diagnosis. You wouldn't take every patient who came into the emergency department who had flu and say, we're going to put you on ECMO, which is what hypothermia was used for in the DECRA trial. Well, not quite, but less severe respiratory failure. Everyone who came in with community-acquired pneumonia, you wouldn't put them on ECMO, which is what happened in the DECRA and Eurotherm trials. And you wouldn't expect to prevent more severe respiratory failure. You wouldn't use it prophylactically to prevent severe respiratory failure. The analogy is similar to hypothermia. There's a similar risk-benefit calculus. There was no benefit of early treatment in polar and Eurotherm. However, the role in refractory ICP elevation has not been tested, and this is a typical context for use of hypothermia. There are few treatment options, but good outcomes are possible, and for hypothermia, we need a trial. We have that trial for decompressive craniectomy, though DECRA showed no benefit. The rescue ICP trial run from Cambridge showed that there's a benefit in terms of outcome for the most severely injured patients with the highest ICP. So that thesis applies. So we've been talking so far about about desperate disease, the most severely ill patients. But what about less severe disease, which is what most of us take care of most of the time? Well, to start off with targets, the Brain Trauma Foundation protocols use population averages for CPP targets, and the recent updates include differences with age and autoregulation. But we know that optimal CPP varies across individuals. So some of these patients are undertreated and others are overtreated. And we need better tools to understand what's the dose of ICP, to quantify its downstream effects, and to titrate the therapies we use for ICP and CPP optimization. If we don't, we wind up with this sort of a picture. It's from our one size fits none line. And as a consequence of that, many patients either don't get treated adequately or are overtreated. So how can we refine our targets and decide how to use these sometimes hazardous therapies? Well, we can start off by minimizing side effects of therapy, and we already do that intrinsically within the protocols for our individual units and also the CBIC protocols. The more hazardous therapies come later, and that's perfectly reasonable. We can account for differences in age, and you saw the Brain Trauma Foundation protocols talking about how this might be undertaken in terms of systolic blood pressure targets. And I'll talk a little bit more about it in a minute. We can target an optimal range of autoregulation. I'll talk about that in a minute. Also look at downstream events as a marker, and we'll come to that later. So let's start off by looking at autoregulation. And I'll tell you how we derive in Cambridge the most commonly used marker of autoregulation, PRX. And this is based on the fact that when the mean arterial pressure falls in patients who have cerebral autoregulation, the normal response of the brain is to cause vasodilatation. And in you and me, that vasodilatation will reduce the resistance to cerebral blood flow. So even with the lower blood pressure, cerebral blood flow is maintained. It's essentially Ohm's law. When the voltage drops, to maintain current, you've got to drop resistance. But to drop that resistance, you get cerebral vasodilatation. In you and me, the intracranial cavity is compliant, so there's no rise in ICP. But in someone who's got raised intracranial pressure or has a non-compliant intracranial cavity, this drop in blood pressure triggers vasodilatation because it's what the cerebrovascular circuit knows it needs to do. But that increase in cerebral blood volume will cause increase in intracranial pressure. And then when the intracranial pressure, sorry, when the mean arterial pressure is elevated, then intracranial pressure will drop. So this is what happens when patients are autoregulating. And now if you draw a regression line between mean arterial pressure on the x-axis and intracranial pressure on the y-axis, what you find is it's a negative correlation. When mean arterial pressure goes up, IC goes down. And this is a sign of intact autoregulation. However, when autoregulation is not intact, a rise in in mean arterial pressure causes passive vasodilatation in the intracranial circulation. And as a consequence of that, ICP goes up. And when the blood pressure comes down, the intracranial pressure also comes down. And now the relationship is a direct relationship in someone who's not autoregulating. And as a consequence of that, the blood pressure elevation causes further rises in intracranial pressure. But we can take the regression coefficient for this if you're getting a negative relationship between mean arterial pressure and ICP, then by definition, the R value would be 0 or negative, and PRX, which is the pressure reactivity index, is negative. So where the PRX is over 0, it impairs that there's a pressure passive behavior of the circulation, and as a consequence of that, pressure reactivity is impaired. Now, the brain can do reasonably well with small impairments in reactivity, but when the PRX is above 0.2 or 0.3, then it suggests that the outcome is likely to be worse. You can also do this dynamically within patients. So Lucius Steiner, who was one of our first PhD students in Cambridge, uh, supervised by John Pickard and myself, published this in Critical Care Medicine in 2002. And what he showed is that if you take any individual patient, their blood pressure will fluctuate normally because even in the best intensive care units, there are small reductions or increases in blood pressure that are outside our control. And then if you can measure the PRX at each bin of cerebral perfusion pressure, you find that where the patient is autoregulating, in this case between about 65 and 85 millimeters of mercury cerebral perfusion pressure, the PRX is negative. But below that, it becomes pressure passive, and as the blood pressure drops, there's vasodilatation and the ICP goes up. So this is a failed autoregulation. And similarly, above this, the ICP will rise because autoregulation has failed. In you and me, this plateau of autoregulation is much wider. It's probably between 50 and 150 millimeters of mercury cerebral perfusion pressure. But following TBI, the sweet spot for optimal CPP is much narrower. So what Lucius found was that in retrospective analysis, 66% of our patients showed a CPP zone of optimal vascular response. And this was hugely variable. CPP opt, the optimal CPP, this nadir, where the PRX and autoregulatory capacity is most optimal, where the brain is best suited to deal with changes in blood pressure, either increases or decreases, varied between 50 and 110 millimeters of mercury. And he also found management at or close to CPP opt was associated with better outcomes and made the suggestion that CPP opt provided a possible target for individualized CPP management. So Lucius has gone on from this. He's now the professor of anesthesiology at Basel. But this provided a basis for a trial, phase 2A trial, which I'll talk about very briefly later to see whether this is technically implementable in an RCT. So we have the evidence of optimal CPP. We have PRX as a measure of autoregulation. And in this paper from Enrico Sorrentino, on which Marek Czosnik and I were joint senior authors, what he did was to look at our 450, 500 patients over the previous few years and looked for statistical thresholds for survival and favorable outcome. This is unfavorable outcome being dead or disabled. And what he found was that if the ICP was over 23 millimeters of mercury, the chances of survival were worse. And if it was over 22 millimeters of mercury, the chances of favorable outcome, achieving survival with independence, were worse. But this was in the group of patients who were 55 or less. Similarly, the CPP for survival and favorable outcome was 70 millimeters of mercury, and the autoregulation for survival was zero point 0.3. So you would autoregulate if you were autoregulating poorly, but not too poorly, you could still survive, but you needed to have a negative relationship between ICP and CPP to have a favorable outcome. So this is under 55 years of age. But over 55 years of age, everything changes. The ICP threshold for survival is 2 millimeters lower. The ICP for favorable outcome is 18 millimeters of mercury. And these may seem like small differences, but remember, these are across populations. And so they indicate a direction of travel that's quite significant. The CPP for survival was higher. There was no clear threshold for favorable outcome when it came to CPP, and there was no clear threshold for autoregulatory indices. So what did this mean? The first, that for all associations, the threshold for survival was less demanding than the threshold for favorable outcome. So you could get away with an ICP of 23 and survive, but you needed to get the ICP that bit lower to have a favorable outcome. And the implication is that the pathophysiology needed to be less severe, or ICU maintenance of physiology much more precise to convert survival into good quality outcome. There's also the issue about older patients. Older patients have lower ICP thresholds for all outcomes. They tolerate intracranial hypertension less well, and higher CPP thresholds for survival. They tolerate hypertension poorly, and less evidence of autoregulatory benefit, so they can't compensate for BP fluctuations. And so in the older patients, and this is not very old, this is over the age of 55, you have to be very precise with your physiological control. This is an example of how we use CPP opt in our unit. So here's a patient who's come in, and you've got the CPP as a continuous yellow line. The ICP is a white line. And what you can see is that the initial CPP is 60 millimeters of mercury, because we follow Brain Trauma Foundation guidelines and CBIC guidelines now for our initial management of patients. So you have 60 to 70 running, up to 80 running in our patients. But this is associated with rises in ICP. And as a consequence of that, we look at the CPP opt curve, and we find that the CPP opt here is about 68 millimeters of mercury. That's the optimal CPP in this patient. Having looked at this and seen that the autoregulatory range is between about 60 and 75, we then push the blood pressure up above the CPP opt, and we now have it running at just under 70 millimeters of mercury. And as a consequence of that, what happens is that the ICP comes down and stays low, and occasionally when it drops, when the CPP drops below the optimal CPP, you get little bumps in the ICP, which we control with better blood pressure control. So this provides a very rational way to proceed. We can see this kind of behavior in between 50 and half and 2/3 of our patients. The others, it's not technically possible to generate a CPP opt curve. And it's important to take this into account. I said that these are all associations. The CPP opt provides information about instantaneous, globally average cerebrovascular physiology. It takes no account of regional variations. So supposing you've got a big contusion and pericontusional edema, the behavior is not going to be the same there as in the rest of the brain. So we use CPP opt as a guide rather than slavishly following very high CPP ops or very low CPP ops. We would just use that to inform how we set targets for patients. So this is about autoregulation. What about the downstream effects? So the downstream effects are best looked at with this cartoon. We have a blood pressure which is pushing blood and delivering a cerebral blood flow through the cerebral perfusion pressure, which is the difference between intracranial pressure and blood pressure. And the consequence of this is you deliver substrate and oxygen to deliver energy to the brain. However, if you have raised intracranial pressure, in this case because of a large subdural hematoma, you have a very high intracranial pressure, cerebral perfusion pressure drops, and then oxygen in the first instance is unavailable, and glucose, instead of being converted to carbon dioxide and energy, is converted to lactic acid. So to address these deficiencies in substrate and oxygen delivery, we can actually use multimodality monitoring. And in the severely injured patient who comes to Cambridge, we will also, alongside an ICP monitor, insert a brain tissue PO2 probe and a microdialysis catheter, which interrogates the biochemistry. I should say that currently we're not putting brain tissue PO2 catheters in simply because the company that makes it for us have moved their manufacturing base from France to Switzerland, and they no longer have European approval for their devices, and they're in the process of regaining this. So currently, we are managing without any brain tissue PO2 probes, and that is a bit of a challenge, but hopefully that regulatory issue will be sorted out by the company soon. We'll start to get these catheters again. So what we do is to use the ICP monitor to monitor intracranial pressure. The oxygen is monitored through the brain oxygen probe, and the lactic acid and lactate pyruvate ratio through the microdialysis catheter. The normal ICP we know is about 10 millimeters of mercury, or even less in you and me. The treatment threshold is around 20 millimeters of mercury, and the life-threatening threshold, which may result in herniation, is above 30 millimeters of mercury. How much above, we don't know. So the initial target we use is 60 to 70 millimeters of mercury, and we recognize the variation in optimal levels. And we use these monitored variables to define patient-specific targets. So there have been loads and loads of papers, and what you can see is the various thresholds from the papers. Those of you who are interested can look at these papers. And the brain tissue PO2 has variably been described in terms of thresholds of 15 millimeters of mercury, 20 or 25 millimeters of mercury, the lactate pyruvate ratio, an index of anaerobic metabolism of 25 or 40 for late atrophy, brain glucose levels above 0.5 or above approximately 1 millimole in the brain, and the PRX as less than 0 or less than 0.3, 0.25. And what you can see is that there are multiple thresholds, and what you find is that the most stringent thresholds, for example, 20 to 25 millimeters of mercury for brain tissue PO2, is a threshold for better quality outcome, whereas the lower threshold is for survival. We also know that some of these thresholds vary with age and gender. You've already seen the Sorrentino paper as an example, and these can potentially provide patient-specific based on autoregulation. So how do we use this? Well, we know what the normal physiology looks like. The normal physiology is an ICP of 10 or below. The PRX, index of autoregulation, is well under 0. If you have a jugular venous catheter in, the saturation of blood coming out of the brain should be 65 to 70%. The brain tissue PO2 should be about 30 millimeters mercury. The lactate pyruvate ratio should be less than 25, and the brain glucose should be well over 1 millimole. We recognize that in brain injury, we may not achieve these targets, but we have some desirable targets. We want the PRX to be pretty much the same, ICP to be much less than 20. In fact, the more recent threshold suggests 18 millimeters of mercury may be a more reasonable threshold. Brain tissue PO2 of 20 to 25, lactate pyruvate ratio of less than 25, and the brain glucose of keeping it over 1 millimole. But if the ICP gets much above 25 millimeters of mercury, the PRX is very bad. The jugular venous saturation is substantially lower. Brain tissue PO2 drops below 15, or the lactate pyruvate ratio gets above 40. Brain glucose from microdialysis drops very low. Then we know that these patients have problems not just with favorable or unfavorable outcome, but survival. So what this means is that this can be used to titrate acceptable treatment intensity. We use less hazardous therapies to achieve this, and more hazardous therapies are reserved for this. To use an American expression, this is to make the juice worth the squeeze, and we use these graded thresholds to escalate treatment in an individualized way and detect and minimize treatment harm. But it's important to have one caveat. This current evidence, as I said before, comes from associations between targets and outcome. And it's a reasonable basis for treatment when no other evidence is available, but causality and tight randomized controlled trials are needed. And emerging trials are now assessing this approach. Boost 3 and Bonanza are trials looking at the use of brain tissue PO2 monitoring, Boost 3 in North America, Bonanza in Australia and Europe. And the Cogstate trial, which was recently published, is a phase 2 trial looking at the feasibility of CPP opt-based therapy. And over the next 3 to 5 years, I think this evidence will emerge and really inform how we manage patients in this way. I'm just going to finish by giving you an example of how we use it to titrate therapy. When patients have raised intracranial pressure, we hyperventilate them. And that's because the cerebral vessels are exquisitely reactive to pH. When the hydrogen ion concentrations rise, then they vasodilate. When the hydrogen ion concentrations in the extravascular compartment fall, they vasoconstrict, because essentially CO2 is a diffusible acid. So when you do that, what happens is with hyperventilation, cerebral blood volume will drop, and this 4 mils per 100 grams of brain is that component of the cerebral blood volume which is amenable to such CO2-mediated reduction. It's not the blood in the venous sinuses of the brain, but the resistance and capacitance vessels in the parenchyma. But as any plumber will tell you, if you reduce the size of the pipe, you'll also reduce the amount of blood going through it. And since flow is proportional to the fourth power of the radius and volume only to the square of the radius, the CBF curve is much steeper. And you can see that every time there's a reduction in cerebral blood volume, there's also a reduction in cerebral blood flow. This means that for hyperventilation to be beneficial, the change in ICP has to be really, really substantial. And that only happens in patients who have a non-compliant brain. To use hyperventilation in patients because the CPP is suboptimal simply does not make physiological sense. It's physiologically illiterate. It's used primarily as a means to control ICP when other means have failed. And why is that? Because we know that when the ICP is less than 20 millimeters of mercury, it causes ischemia to hyperventilate patients. So this is John Cole's data from John Cole's PhD. John is now the head of the department in Cambridge. I retired last year. I'm just mainly research focused and doing some clinical work. But what John did for his PhD was to take patients in who had a TBI, get baseline blood flow scans. This is perfusion scans with PET at CO2 of 5 kPa, 38 millimeters mercury, and anything that's less than 20 mils per 100 grams per minute is picked out and read. And at that stage, we were routinely hyperventilating patients down to 25 to 30 millimeters of mercury CO2. So we got this patient, it was one of our first patients, down to 25 millimeters of mercury. And we never did this again because when we hyperventilated it, the whole brain became ischemic, and we rapidly reversed it in this patient to make sure that they didn't come to any harm. So in patients where the ICP is only modestly elevated, in the low 20s or less than 20, using hyperventilation is a bad plan. So what sort of CO2 level should you target? Well, there's no completely safe degree of hyperventilation, but CBF reduction is relatively mild at CO2s over 4.5 kPa, so that's above 35 millimeters mercury approximately, but particularly severe at CO2s below 4 kPa, that's 30 millimeters of mercury. And from that critical care medicine paper, you can see this is the starting CO2, and this is the finishing CO2 in white and light gray. You can see that there are threshold values around 35 millimeters of mercury and 30. Above this, things look pretty good, except in individual patients. Gets a bit worse at relatively modest levels of hyperventilation, but you get worse than that, the ischemic brain volume goes up substantially. So we can't take patients in for PET scan repeatedly, so we use brain tissue PO2 for this. And what you have is a long period of monitoring from one of our patients, and this is the whole week starting from the 30th of August and going to 6th of September. You have the intracranial pressure up here, the carbon dioxide level. This is actually end-tidal, but this was a young patient, so the correlation was very close. So it can be used as an index of arterial CO2. And the brain tissue oxygen level in blue up there. And what you can see is over the initial few days, we were struggling to keep this patient's ICP reasonable. It was getting up above 30 with spikes occasionally, came down, but much of the time it's above our threshold of 25 millimeters of mercury, where we treat with more aggressive therapies. And you can see that much of the time the CO2 is above 4.5, but occasionally it gets down below 4. And I've told you that CO2 levels below 4 kPa, 30 millimeters of mercury, associate with more ischemia. The reason we were able to do this and not worry about it is because we were monitoring brain tissue PO2. And you can see that the brain tissue PO2 was maintained in all of these instances above 15 millimeters of mercury, which is our threshold in Cambridge. So what this means is we can use the an index of brain tissue PO2, either SgO2 or brain tissue PO2, to make sure that we're not causing brain hypoxia, recognizing that if you're using brain tissue PO2, the focal measurement and may miss ischemia elsewhere. But the most important thing is to consider why you're hyperventilating. If it's for perfusion pressure optimization, it doesn't make sense to use an intervention that drops the perfusion. If it's for impending herniation, a temporary CO2 down to 25 millimeters of mercury is worth the side effects, but it's important to use this as little and as briefly as possible. So I've talked to you about the algorithm as we use it, but just like for the ICP on its own, there's been an algorithm that's developed by the CBIC conference for the combination of ICP and brain tissue PO2. Microdialysis is not used as commonly, so it wasn't integrated into this. And what this does is to divide patients up into 4 groups: type A, where the ICP is low and the brain tissue PO2 is high; type B, where the ICP is elevated, but there's no brain hypoxia; type C, where the ICP and there is ICP elevation and brain hypoxia. And here, I'm sorry, type D, where both are there, and type C, where the primary problem is brain hypoxia, but not intracranial hypertension. And each of these pictures have different physiological signatures and different treatment requirements. So type B is when the ICP is elevated but brain oxygenation is normal. You can afford to have a little more leeway with using hyperventilation, for example, as I showed you. In type C, where the ICP is elevated and brain tissue PO2 is low, you've got to be careful about hyperventilation. Osmotic agents are much more displayed, and you also use blood pressure elevation. And when you have the ICP elevation and brain being hypoxic, then you can use the standard management that we have. It's important to say that this derives some novel but rational inferences. Consider this situation here in type C, where the ICP is low, but brain tissue PO2 is also low. Here, you can actually push the CO2 to supranormal levels, and we have used this occasionally, getting CO2 up to 45 to 50 millimeters of mercury to restore brain perfusion because you're not worried about vasodilatation and rise in ICP. Much more commonly, we will normalize CO2 in this situation because the ICP does not require it. We haven't got microdialysis here, but similarly, when the brain glucose is low, we can push blood glucose up to 100, 150 millimeters of mercury to restore brain glucose because that restores substrate availability to the brain. So I'll finish with these take-home messages on multimodality monitoring to personalized TBI care. It's important to recognize that patients vary in physiology after TBI and hence in optimal ICU management. ICU therapies for ICP and CPP management after TBI are not risk-free. Tier 3 therapies, decompressive craniectomy, hypothermia, and barbiturate coma are hazardous, and we need to titrate therapy intensity to need. Desperate therapy should be reserved for extreme physiology. As for Tier 1 and Tier 2 therapies, we should individualize them to minimize harm, and the options include to account differences in age, to target optimal range of autoregulation, as I showed you using PRX, and to use downstream events as a marker, tissue oxygen partial pressure, substrate adequacy, glucose, and metabolic compromise by looking at the lactate pyruvate ratio. Thank you very much.
I'm sure all of you had a better understanding of what precision medicine and what all to monitor when we manage a patient of traumatic brain injury. Following this talk, the next talk will be by Professor Umamaheswar Rao. Sir has held the post of Professor and HOD of Neurocritical Care Neuroanesthesia at NIMHANS, has been the Dean of Neuroscience and the Director of NIMHANS. Sir has won the prestigious BC Roy Award for the Best Teacher in the year 2016. He has multiple publications to his credit, and every neurointensivist practicing in India has either heard of him or has been trained by him, so he needs no introduction at all. And Sir will be covering a very important aspect of care when it comes to traumatic brain injury, that what happens at bedside and what are the lessons as intensivist through this journey Sir has taken. So this would be Sir's talk.
Good afternoon, ladies and gentlemen. It's indeed a great pleasure for me to take part in this afternoon scientific program. And I thank the administration of St. John's, Dr. Moses, Dr. Matangi, and Dr. Soumya for giving me this opportunity to speak to you this afternoon. Before I start my lecture, I have to make one confession that this is not a highly scientific discourse like what Dr. Menon has done till now. But it is just a recollection of some of the patients who left their indelible mark on me in the last 40 years of my practice in neurocritical care. So let's start. According to ICMR statistics, per year, there are 1 million head injuries in this country, of which 1 lakh people die. At the end of their hospital stay, 5.5% people have died, 4% are discharged in a persistent vegetative state, and 15% of the patients are left in severe vegetative state, and 37% have moderate disability. And about 30% of the brain injured patients at 2 years of discharge have a poor outcome. So this is a survey that was conducted in NIMHANS about 20 years ago, where 7,000 patients were recorded, of whom 70% had mild head injury, 15% each had moderate and severe head injury. By the time they were discharged from the hospital, only 47% had good recovery, 29% had moderate disability, 14% had severe disability, 4.8% died, and 2.6% were left in vegetative state. This is the CT scan of a patient with head injury with midline shift with some underlying edema. This patient is likely to have raised intracranial pressure and he would require surgery. This is another patient who had subdural hematoma with massive underlying edema and midline shift. This patient also requires surgery. Here is a patient who has right frontal contusion with underlying edema and compression of the cisterns. He also is likely to have raised intracranial pressure and requires surgery. On the other hand, here is a 25-year-old young man who came in a GCS of 7. His CT scan looks normal. No midline shift, no compression of the cisterns, and no edema. But still his GCS is low. This is what we refer to as diffuse injury type 1. And here is another patient who was in a GCS of 5. His midline is slightly shifted, but his cisterns are still not compressed. He has some edema and some small specks of hematoma. So this is what we refer to as type 2 diffuse edema. And here is a patient with type 4 diffuse edema who has severe edema, breath assistants are compressed. He is supposed to have raised intracranial pressure. Now, why did I show you all these things? I just showed you all these things to say that patients with head injury come with different types of problems to the emergency department. And we admit them to the intensive care unit and we treat them with the hope that we will give them the best outcome. But with all the advancements in medical sciences till now, we are not able to predict with accuracy what is going to be the physical, mental, and social outcome of an individual at the end of his treatment. So that's what probably Hippocrates meant when he said, no head injury is too severe to despair of, nor too trivial to ignore. So what I'm going to do today is to recollect a few patients who have left an indelible mark on my memory in the last 40 years of my service. The first patient is a 20-year-old boy who was admitted with a traumatic brain injury. He was ventilated for 1 month and he was off ventilator and he was in a persistent vegetative state. His father was a member of a parliament who bought from pressure from the director of the institute to do something to improve his status. Out of sheer desperation, we gave him some parenteral nutrition for 1 week. And then after a few weeks, we discharged him. 1 year later, an old gentleman met me in the corridor and introduced himself as a member of parliament. I could recognize him. He asked me to have a look at his son, who was sitting in the windowsill of the recovery ward. I couldn't believe that it was the same person who was discharged in a persistent vegetative state 1 year back. He said he was going to the college, he was doing everything. He had a small request for me. He wanted me to recommend to his father to buy a car as he was not able to ride a scooter with the foot drop that he has. So what did this man teach us? Never underestimate while prognosticating head injured patients. That is what this study has shown. Study which was published in 2021. Patient with moderate to severe TBI frequently demonstrated major functional gains, including recovery of independence between second week and 12 months after post-injury. Severe impairment in short term did not portend poor outcomes in substantial number of patients. When discussing prognosis during the first 2 weeks after injury, clinicians should be particularly cautious about making early definitive prognostic statements. So this boy taught us that we should never consider a patient to have a poor outcome early during the course of their hospital stay. The second patient was an electrical shop owner near my house who was found in our ICU on one morning. The history was that he was found roadside after road traffic accident. I was the first person to identify him. I sent word to his relatives. He had a severe traumatic brain injury with a temporal contusion and a chest injury. His GCS was 4. With appropriate care in ICU, he improved to a stage where he could be mobilized to a chair. He was opening eyes. He was in a vegetative state. In this state, he was discharged home. After a few months, I met his sister, who said he improved significantly. He was walking, talking, having food, and doing all the things. I was very happy. But a few months later, I met the same sister again. This time, she said she was admitted to the psychiatry wards. His emotional outbursts have become so intolerable for the family that they had to seek a psychiatrist's help. He had erratic behavior. He would fight with his family. In the middle of the night, he would climb up the stairs and threaten to commit suicide. His sister told me that he would have been better dead than survive like this. I ruminated over his condition. What did we do? We saved a life and felt happy about it. But what did the family gain? Additional burden. So this patient taught me a lesson that social outcome is different from medical outcome. So that's what this study published in 2020 in Frontiers of Neurology has shown. At the end of 6 months, overall, 24% of the patients show serious behavioral disturbances. And the behavioral disturbances are 3 times higher in moderate to severe head injury compared to mild traumatic brain injury. Moderate to severe traumatic brain injury showed irritation and disinhibition, and half of these patients did not return to work. So the next patient is a very interesting lady who was admitted to our ICU following a surgery for head injury. One afternoon, the sister in the recovery ward came running to me, said, the last bed patient has stopped breathing. In a moment, we rushed up to the last bed and we, using our resuscitative skills, we intubated her, and then the monitors are beeping away to glory. So ultimately, we felt happy that we saved a patient from a collapse. She remained on ventilator for another 2 weeks and then gradually regained her consciousness. She was taken off all tubes and catheters, but there was one big problem. She could not talk. Strangely, nobody missed her anywhere. So we continued, she remained continued to remain unknown, and for want of a better name, the doctors and nurses used to call her Ananama. So, and one evening when I was returning back home, I stopped by the surgical wards, and I was pleasantly surprised to know that Ananama was talking. She narrated her story with such lucidity that it was impossible to believe that she was a patient who had head injury 2 months ago. She said she was married, has 2 children. She gave the names of the children. Her husband deserted her. When she returned home, her brother did not. He was infuriated. Hit her with a lemon. She fell unconscious. After that, she doesn't remember anything. So now that she has become conscious, she gave me the contact numbers of her family. The family was located, but the family refused to take her back home. Eventually, she was handed back to the police and she was sent to a remand home. So what did this lady teach us? After all the effort, we are not able to give her a decent life. The next patient is a 4-year-old boy who met with an accident while waiting for his bus to go to school that morning. He was brought in an unconscious state. He had abnormal motor posturing. His pupils were small but not reacting to light. But his blood pressure was normal. Respiration, he has moderate tachypnea. He did not have any other injuries. He was sedated, ventilated, fed through Wright's tube. At the end of 1 month, he was opening his eyes spontaneously. There was some motor posturing still. On Wright's tube feeds, he was discharged home. We never thought of greatly about this child, but to our surprise, 1 year later, his mother brought him to invite us to his birthday. So he was conscious, playing, hyperactive, and slightly obese. His mother told me that she was taking him to an endocrinology consultation where he was diagnosed to have pituitary disorder. So this patient taught me a lesson that after good clinical recovery, the patient may have severe endocrinal disturbances and attention deficit and hyperkinetic syndrome. So that's what this study published in 2015 says. At 5 years after moderate to severe traumatic brain injury, nearly 30% of children suffer from hypopituitarism. And this study in 2018 suggested that the incidence of ADHD, attention deficit hyperkinetic syndrome, is present in children who have traumatic brain injury at a young age. The next patient is an IT engineer, about 40 years old, found unconscious in front of Vidhan Saudha. He was brought to NIMHANS. At admission, his GCS was 4. Pupils were dilated, not reacting. He had a frontotemporal contusion and subdural hematoma. He also had a chest injury. He underwent craniotomy and evacuation of the clot. Postoperatively, he was connected to a ventilator. 3 months on the ventilator, he did not show any improvement. His father was a famous pediatric surgeon in Tamil Nadu. He insisted that the treatment be continued in spite of the fact that the patient did not show any improvement for 3 months. He was so adamant about his decision that he insisted that the patient should be treated in spite of all his relatives, many of whom are doctors, trying to convince him against it. We had no alternative but to continue the therapy. Finally, we arranged to shift him in an ambulance to Madurai. Those are the days when ambulances were not very freely available. That to shift from Bangalore to Madurai. So we shifted him to Madurai. After a few weeks of stay on ventilator, he died. So here in this patient, the patient's father taught us a lesson. However educated the person is, he still expects miracles to happen when his relative is involved in a head injury. Probably our communities were not.
ಬ್ಲಡ್ ಕೇಳಿದೀರಾ ಹೈಪೋಟೆನ್ಷನ್ ಇದೆಯಾ
So our communication skills were not probably enough to address the father with regard to the uncertainty of the outcome of the patient. The next patient is a very popular mathematics lecturer in one of the popular colleges in Bangalore. At 11 o'clock in the morning, I got a call from the angio room saying that a patient stopped breathing there. I rushed to the spot, I intubated him, I gave some IV fluids, gave some inotropes, and settled his respiration and cardiovascular status. And the radiologist continued his angiogram and declared that the patient has a diffuse injury. That was a pre-scan, CT scan days. He had a flexor response and pupils were sluggishly reacting to light. Patient was, as I told you, a popular mathematics teacher in one of the well-known colleges in Bangalore. That morning, he finished a tuition class and was returning home on a two-wheeler when he met with a road traffic accident. Post-angio, he was shifted for mechanical ventilation. He was treated with anti-edema measures and other supportive measures. After about a week of therapy, he was extubated and shifted to the ward. That was the season of annual examinations. His students used to come to meet him. About 2 weeks after the accident, I was surprised to see him solving the examination question paper for his students. So what did he teach us? He taught us that early intervention results in best outcomes. So if I had not intubated and improved his respiration, and if I had not given the inotrope and IV fluids and improved his blood pressure that time, he would not have been solving the question paper for his students just 2 weeks after the accident. So that is what Chestnut has shown in 1993. So hypoxia and hypotension are common and detrimental by causing secondary brain injury to the patient. So if we had not intervened him on that day, he would not have had this good outcome. This is a very, very interesting patient. He was a 13 or 14-year-old boy who was admitted to our ICU following a craniotomy for a temporoparietal contusion. His GCS was 7, his pupils were reacting to light. He was on ventilator. He received mannitol and other supportive measures. About 5 days into the treatment, his motor response dropped to 1. The surgeons gave up. But there was one correctable anomaly in this patient. He was hyponatremic. We went ahead and corrected the hyponatremia. He started improving. He improved to the extent that he was extubated and shifted to the ward over a period of time. Slowly his activity improved and he became fully conscious. He was slowly, there was one problem. He was unknown and he remained unknown. He was aphasic too. There was no way that we could find out his name or his parents' whereabouts or his home address. He was so active that he would get up early in the morning, have his bath, have his food, and he would even assist the nurses during their work, but he could not talk. In the whole story, there was one policeman who brought him to the hospital on the day of accident. He would visit him frequently for official reasons. Slowly, he got attached to the boy, and he would bring some eatables and clothes for him also. He also could not elicit any information about his identity. At last, he thought of an idea. He proposed that he would take him back to the same place where he was found. So he did the same thing on his motorbike. And once he reached the site of accident, the boy jumped off the motorbike. He went straight into a house where the parents recognized him. And then he was brought to the hospital and discharged in a proper way. So this patient taught us more than one lesson. Never ignore even a minor physiological abnormality. It may be the only thing that might turn around him. So if I had not corrected hyponatremia on that day, he would have succumbed to the head injury. Number two, patients with head injury may have communication disorders, like this patient had aphasia. Number three, it may be a difficult task to find the identity of an unknown person. Here is one patient from whom we learned a lesson in a very hard way. A 60-year-old man was admitted to ICU following road traffic accident. He had a small contusion in frontotemporal region. He had flexor response to pain. He was opening eyes to pain and pupils were reacting to light. He was on ventilator, but he would not come off ventilator even after a week of ventilation. He had chest infection, had signs of COPD. So we started him on steroid, and a few days later, he was successfully weaned off ventilator, extubated. After a few more weeks, we decided to discharge him, but the family decided to take him to a private nursing home. We shifted him to a private nursing home. We shifted him in the morning. The same evening, the relatives came and told me that he passed away because of uncorrectable hypotension. I asked the resident who wrote the discharge summary whether his discharge summary contained steroids. He verified it and said they were not there. So this is the acute withdrawal of steroids in a COPD patient that caused the death. So from this patient, we learned the lesson that a small negligence can cost the patient's life. And the literature says the recovery of hypothalamo-pituitary axis might take several weeks to months. The last patient is the wife of a British Council librarian, wife of a British Council librarian, who was admitted with a contusion and subdural hematoma after road traffic accident. She was operated upon. She was following commands, opening eyes spontaneously. A couple of days later, she became drowsy and unresponsive to commands. That time our CT scan was not working, so it took another day to get the CT repeated. The CT scan showed an extradural hematoma, which was promptly operated upon. She remained on ventilator for some more days and was discharged. After several months, I got a phone call from the principal of my old college. It so happened that he was the patient's brother. He called up to say that the patient is doing well. She was able to cook for the family and was able to do her daily activities. Now she has to undergo a hysterectomy, and the principal wanted to know if there are any special precautions that need to be. I gave him some advice, and later on the patient was doing well. What did this patient teach me? She taught us that never to overlook delayed lesions. So the benefit of obtaining follow-up imaging must be strongly considered in a traumatic brain injury patient. Subdural hematoma is a common intracranial lesion seen after traumatic brain injury, and development of contralateral delayed extradural hematoma is a well-known complication. That is what exactly happened in her, and we recognized it in time and treated. So she was doing it. Like this, several patients taught us several lessons, and whether we did better after learning those lessons, I'm not very sure. Thank you.
I hope all of you enjoyed this expert talk on traumatic brain injury. On behalf of Neurocritical Care Society of India and Classroom Series, I wish to thank St. John's Medical College once again for providing the recordings and hope this inspired us and gives us an aspiration to become better clinicians as we treat traumatic brain injury on a day to day basis. Thank you very much.